Okay. Alrighty. So I've been really lucky over the last couple of years to get to go over to the UK, and I went to Sheffield. They have 4 OI main centres over in the UK for paediatrics, and I got to visit one of those for a couple of days. And then last year I actually went to Montreal and I got to visit the Shriners Hospital there, which for lots of people who know about paediatric OI, it's kind of like the place in terms of the setup. And they have great therapists there as well, which is what's been really exciting for me at both of those centres. So I guess I just wanted to talk a little bit about what I've learnt from travelling around, from working at Westmead, from working with other people. I'm spending some time in Melbourne at the moment as well. And please shout out and ask questions at any point in time, okay? So this is probably a pretty stock standard type of slide in terms of who might be part of a multidisciplinary team for people with OI. Whether you are a child or an adult, you may come across 1, 2, all of these people within your time, or you may end up only having one. So these are people who you may come across over your journey. What we know now though is that you've had lots of people talk to you about medication so far. So Jenny Gunton spoke this morning, Prof spoke this morning, Craig spoke last night, and the doctors are getting really, really good at managing OI with medication. There's new meds coming out all the time. So they're kind of doing everything they can within what is currently available, and it has absolutely revolutionised OI. But as therapists, we're just starting to really be able to get on board and take control with a little bit more work, pushing people a bit more, helping a bit more, because those medications are now on board. So we've got better bones to work off for the muscles to get things happening. So just an example of this is actually a paper that one of our fellows published a number of years ago now, where you can see in these kind of red coloured bars, that was a group of children with OI, actually data from the Netherlands who hadn't had bisphosphonates, and the age at which these children were achieving different developmental milestones. Oh, sorry, I've got it the wrong way around. The grey is that. The red was our cohort, and that was kids who had started having bisphosphonates with moderate to severe OI under the age of 3 years. So what you can see is that when kids are being treated, they're reaching these developmental milestones so much earlier, which means that as physios, we can now really try and help get people moving. We're getting more engagement with schools and physical activity and all those types of things. So therapy altogether is becoming a much bigger deal these days compared to previously. So we've got the medicine right, but what about the rest of us? So please correct me if I'm wrong here, but to the best of my knowledge, we currently have 3 multidisciplinary clinics within Australia. So clinics which are functioning where you can actually see more than just one doctor in the room at the same time, and preferably you may even get a therapist or an allied health person at that point. So we've got the clinic at Westmead Children's, which has been running for a very long time, that Prof and Jenny started a very long time ago, 30, 40 years ago. We have a clinic down in Melbourne at RCH, at the Children's Hospital there. It's been going for about 2 years. So they have the endocrinologists and they have physio and OT. And just in the last 6 months has been a clinic in Perth where they have the endocrinologist along with a physio and a social worker. To the best of my knowledge, there isn't an adult multidisciplinary clinic in Australia at this point in time. There are people you can refer to and consult with, but not dedicated staff to a service. That's kind of the way it's,
Queensland is starting that as well, so the Children's Hospital in Brisbane.
Oh, fantastic.
Yeah, so
that's really good. With Di Jensen?
Yep, and she's the lead of it.
Oh, good.
Yeah.
Really good. She hasn't told me that.
I'm pretty sure it's her or, I'm not sure who's retired, but they just started within the last 6 months as well.
Oh, great. So it's happening in Queensland too. It's pretty similar to what's happening in other places around the world. There are multidisciplinary clinics for children in most developed countries, but there is very little for adults. There's kind of blurry lines, like over in the US, they will often see up to the age of maybe 25, 21, those sorts of things. But it's quite different around different places in the world. In New York, for example, it's an orthopaedic surgeon who leads the OI service, rather than being an endocrinologist or a geneticist. So it just differs, and it depends on where you live and who's around and who's got the knowledge. So I think generally speaking, not everywhere, but generally speaking, Australia is actually doing really well. The services we had set up in Sydney are like one of the leading services very early on in the world for providing multidisciplinary management, and other centres are coming on board too. So we're getting there. We all know, many of us know what we want, but we don't have it yet, and it always comes down to dollars, unfortunately. So I thought I'd just talk a little bit about what a multidisciplinary team is, and there's lots of different terms out in the literature. So you may come across these three terms: multidisciplinary, interdisciplinary, and transdisciplinary. Basically, for each of those, you have a group of people of different health professions who are all working with one patient. Multi, you tend to be working a little bit more separately. Transdisciplinary, you might start to have more joint goals. And when you get, interdisciplinary, more joint goals. And when you get to transdisciplinary, you'll start to have more joint actual sessions, and you may even have a much more blurring of the roles of health professionals. So for example, at Westmead Kids, I think there's quite a bit of blurring between, say, OT and physio at different points in time, but there's also some areas which are really OT and some areas which are really physio as well. So a lot of different services will work across those different things. And that's just a graphical representation of that. So working separately, a little bit of overlap, or really all working as one together. So what does a multidisciplinary team do? What are we thinking about? How do we try and put it together when a patient comes in the room for us? We think about these three things. This is what we refer to as evidence-based practice, meaning that we're referring to the literature, but it's not just that. It's about lots of different things. As you've all heard already, there's not a lot of literature about a lot of things for OI. So when it comes to it, we often refer a lot to clinical expertise. And that's where, as therapists, as doctors, we figure out what's an impairment, what are the things people are having difficulties actually participating in at this point in time. And that's us looking at you, asking you questions, doing assessments, those types of things. But that's really not enough. We need to be finding out about you. So about what your goals are, what your preferences are, and taking that into account with what we're seeing as well. Then we need to put it with the evidence to start to try and make it effective. So we might then start thinking about implementing a treatment, doing something differently, if we know that if we don't do something, it's not going to get better, or if we know that doing something is going to make it better. And they're actually slightly different things, because there's a lot of things out there where we think we can help, but we don't have the evidence yet. So you put all that together, that's what we're trying to achieve as a multidisciplinary team. But I guess it's very much about, and even more so moving forward, about really trying to have you guys as the patients engaged in decision-making processes. Whether that be choosing whether you have zoledronate or pamidronate, or choosing whether or not you're going to do a block of therapy or not, or see a particular specialist. And there's a few new things which are starting to come out. That first pop that I have there is actually taken from some work I was doing with an orthopaedic surgeon and an OT, where you have a little look at the literature, and if all a doctor needs to do or a therapist needs to do is actually tell the patient what their options are and spend time having a real discussion with them about their preferences. And in the orthopaedic surgery world, that can be whether or not you are going to have surgery or not, rather than whether you have it now or in 4 weeks' time. You know that if you do that, patients are going to be more satisfied and they will actually have better quality of life outcomes from their orthopaedic management in adults with chronic conditions. That hasn't been done for OI, but for other chronic conditions. Just engaging the patient in the conversation makes a difference to outcomes. I'm sure all of you guys would feel that way. One of the new things which is starting to happen, again, none of this is in the OI world yet, but they're talking a little bit about enhanced recovery protocols. So often in OI, particularly in your paediatric years, you know that you're going to have surgery. So you know at some point in time you're going to have a rod put in, or you're going to have a plate put in to change the growth and the alignment of the lower limbs or something like that. But if you get in early before the surgery, you educate and you prepare not just the parent but the child as well for what it is likely to look like afterwards in terms of how long they'll be in hospital, how they're going to have their pain managed, what their therapy services will look like, that what actually happens, and again, hasn't been done for OI, but it's been shown to reduce the amount of pain medication needed post-operatively for kids, and that it will get people up and get them moving and get them out of hospital sooner. So again, it's just all about communication. And finally, the other thing which is starting to happen more, and I'm sure some of you have probably had it, is this whole concept of prehabilitation. It's really just a word that we've made up. I don't think it's in any way a real word. I don't think you'll find it in the dictionary. But basically it means if you know someone's going to have surgery, try and get in and strengthen them up and get things going before surgery if you can. And I always think at it in terms of, you're sitting here. We know that when you have surgery, you have time off your feet, you're sore, you don't move as much, so you decondition and you come down here. So it's way, way harder to get back up to here to where you're going. So if before the surgery you do some work, you get up to here, then you only drop down to there, so then it's easier to get going again post-op, okay? So again, it's more about preparation with the patient, working with the families, and they've shown that in other orthopaedic conditions in kids. So for ACL reconstructions, which is, you know, like footballers when they do the ligaments in their knee, they'll get back better if they do the prehabilitation. So they injure themselves, they get in and they do some physio and some exercises before they have their surgery, they'll have better outcomes. Similarly, if they've had to do an amputation or something like that, whether it be for cancer or for a known cause, that you'll get a better outcome if you get in and you actually do work beforehand, okay? So I guess this is really the path that we're trying to start taking with multidisciplinary care, being more engaged with patients, being more prepared, and a lot more education and discussion between your health professionals and your individuals. So I alluded to this last night and I presented a little bit about it last year down in Melbourne, but it wasn't published then. This is the consensus statement, which is an international statement, which was published. It's open access, which means anyone can go on and find it on the internet. You don't need any special access. And it was set up and run by the team from Germany, which is Bridget Mueller, who's the therapist, and Oliver Semmler, the physician over there. And we had people from 16 countries, physios, OTs, a couple of doctors, and we did a lot of work based on surveys of a wider group. Then we had a lot of phone calls, we split into little groups, and then we had a meeting for a day, which became a day and a breakfast and a lunch and a dinner and another breakfast type of thing, to try and come to some form of consensus as to what, as an international group, we thought was the way forward for providing therapy and rehabilitation to children with OI. And as I mentioned, it was only for children because they couldn't find people to do it for adults, unfortunately. So from that, it's a really long read. If you're working with people out in the community who don't know about OI and who haven't engaged with people with OI before, great read for them. It's not something which is providing huge amounts of information to people who have a little bit of experience though. It's very broad because when you get lots of people from lots of different places and backgrounds, it's hard to get them to agree on the nitty-gritty. So everything ends up being big statements. But that's easily available if anyone wants to have a look or if you want to pass it on to a health professional. Basically what we came up with, there's not very much literature, there's not much evidence. We know that the needs vary throughout the paediatric years and also throughout adult years. And in there, we've tried to aim for information to promote safety and prevent harm, so things like handling, to encourage development no matter what age you're at, and to promote inclusion and participation, again, no matter what age you're at, to try and get out there in society and do what you want to do. So as I said, we went through that process, and the statements which are in there cover those 7 topics. So if there's something particular you wanted to go and look at, you can just kind of flip through to that section. It's a bit of a long read. The take-home messages are this though. Whether you're a physio, an OT, whoever you are as a health professional, our overall goal is to maximise mobility, function, activities and participation of an individual with OI. And to do that, we need to optimise muscle function. And like Craig mentioned last night, strong muscles make strong bones. So by making strong muscles, you're making better bone as well, bigger bone. And that physical exercise is the key to everything for somebody with OI. And it really doesn't matter a huge amount at this point in time as to what that exercise is. It's just getting out there and doing something that you enjoy to keep you moving, keep you comfortable. And if you can't figure that out, go and talk to someone, a health professional, to help you figure out what that is that works for you, okay? So I'm absolutely against absolute no's and absolute yeses in most cases. It's about what works for you, because everyone has different preferences and is prepared to take different levels of risk. So what it came off was only a couple of papers in terms of the actual research outside of a clinician's perspective, and this was one of them. So this is the only paper that talks about really multidisciplinary rehab for people with OI, and it comes out of Germany. So their setup over there is that for kids, they go in and they will do about a 2 or 3 week inpatient visit where you have your physio, your OT, 2-3 times a day, you have vibration, and it's kind of like your tune-up. So you do it every 6 months or every year, and then you'll continue coming back for kind of 3 to 4 months, a couple of times per week. So it's very, very intensive. And they do that for children with severe OI, but also with moderate. One of the things I did learn when I have started travelling around more and talking to more people is that not many people manage and work with people with mild OI as much as what I think we do here. I think we have a lot of expertise in that area, because over there, whether it's sheer numbers, that it's more moderate and severe OI who are accessing healthcare services, or whether the mild OIs aren't being picked up as well, because perhaps they didn't have the big sort of surveillance early on that we had here in Australia. But a lot of this is for children with more moderate to severe OI. So that's their strategy. They found things improved, which was fantastic. We don't know, because of the way it's set up, whether if the kids hadn't done that, if they still would have improved or not. We don't know if having the vibration alone would have made a difference, or the therapy alone would have made a difference. So it's about individualising that treatment for each person who goes through. At this point in time, what works for you? This is an old paper, and back when we had a conference in Sydney previously, Raoul Engelbert actually came out, who was one of the authors of this, which still to this day is the only RCT, which in the evidence-based world is kind of the top-notch level evidence to show that exercise, that has ever tested exercise in people with OI. So this was in children with OI type 1 and 4. And they found that by doing a supervised exercise program, they got reductions in fatigue and improvements in quality of life. And it lasted for a couple of months post doing the exercise program. And then when the kids stopped doing it, the improvements kind of fell away. But that's the only study we've ever had really assessing exercise at this point in time. And finally, this is a relatively newish paper, which has come out of the UK, where they put children with OI onto some whole body vibration plates, which many people would have heard of. And what they did is they ran them on that for a couple of months, and then they looked at their outcomes. They found that they made more muscle, which was great, but it didn't actually, so more muscle like on a PQCT picture, but it didn't actually change their strength, their mobility, their balance, or any of their quality of life measures. They're all very short-term sort of follow-ups. Often we think about if you make muscle, you then need to have enough time for that muscle to start working to actually then be useful in real world. So to just do a short-term follow-up after an intervention, it isn't necessarily really doing it the justice for what it's achieved. So there may be something in it. We've used vibration plates a little bit in sort of our clinical setting, and I think for some kids it's fantastic. I think for other kids it does not work at all, and it's not the right way to go. But people always ask questions, so I have a video of my son in my messy kitchen, and I'm hoping that this will work because it did before. It's got sound. They're like me, they like a chat. But you can see it's pretty full on. So it's not something you just want to step onto. It is not the same as what you buy in the shopping centres that you see advertised at midnight on TV shopping channels. They're very different. This is an $8,000 plate versus what you see in the shopping centres, which is like $300. This is what you get over in Germany if you go through that kind of program in Cologne. And they're very, very strongly advocating for it being really important. But more and more so, they're starting to say we need to be a little bit cautious. Like, we need to be a little bit cautious if you have rods in place. We need to be a little bit cautious if you've actually got things going on with your kidneys as well. A few things like that. So it's not something you just want to step onto and run with. You need to really make sure that if you want to go down this path, that you're going with a health professional who's got some experience in using it. And there certainly isn't enough evidence at this point in time that I think somewhere like the NDIS would be funding a vibration plate. So it's still pretty early days here in Australia for doing something like that, because you use it for all of 9 minutes a day. So you don't want to have to travel to a hospital and get on a plate for 9 minutes a day. Go and play in the park and move around, and you'll get plenty out of that, which will help your muscle as well. Where it's been really helpful is where people just need that extra kind of push for a little while to go through, and that's where clinically we found it helpful. If people are already doing their rehab and they just need a little bit more because they're too tired or they're too sore or they're just struggling to have enough time in their day to really go hard with their rehab to get that little bit, tiny bit more. So that's where we found it useful. I guess thinking about what a multi-disc service is as well, one of the things which we did last year is we had a good look at our service and said, okay, what are we providing? Because there's things that we would like to provide that we're not. And we were, well, when I say we, I got some of my students to go back through the notes, which took a really long time. And this isn't all of the data, but this was based on almost 90 children who've been through the kids' hospital at Westmead. And it was what services they accessed at our hospital. So they could still be accessing services out in the community or at other hospitals or things like that. So this isn't by any means the be all and end all. And this was children all together, so mild, moderate and severe, over the last 10 years. And what you can see, I'm only going to point on one, but this red bar is physio. Now, it's no surprise kids at Westmead get heaps of physio, because the most allied health time we have for our clinic is a physio. We have 0.5 there. But you could see in that 0 to 12 month age range, 85% of our kids were accessing physio when they were coming into clinic or coming into the hospital for other appointments. Next up was OT. At that point in time, we probably had about 0.4 of an OT to the clinic. So right across all of those ages, you're getting really high access to physio and OT. And then little bits to the other services that we have there, because we don't have dedicated staff to the clinic for those. But you can see that the allied health needs are actually quite high for our population, and even for our teenagers, because people often think, oh, well, it's all in those paediatric years when they're really young and they're starting to move that they need this multi-disc, but they still need it at the end as well. Okay? Yeah. Looking at physio and OT, we have the dark bars, which are your moderate to severe, and the light bars, which are your mild. The blue is your physio, the pink is your OT, and what you can see there is, again, right through the age ranges, lots and lots of involvement of physio and OT, whether you have mild OI or you have moderate to severe OI, and that's just at our centre. And then looking at the different reasons why, we in New South Wales do a lot of work on fracture management and helping out with surgery type things. So as part of that, that's something that we have in New South Wales, which probably bumps our numbers up versus some of the other states where physios don't do that role. But you can see that that's a lot of what we're actually providing. So fracture and surgical management in those early years, and that continues to be the highest one right throughout. But the big one is really musculoskeletal injury comes in for the kids with mild OI, much more in those older age ranges, so like high school based years. Then looking at the children with moderate to severe OI, you get a little bit of managing the musculoskeletal injury, so the dark purple, but not as much. It's much more about things like development, physical function, so that's things like mobility, and looking at sort of post-op, post-surgery based management the whole way through their paediatric years. Now there's a little bit more, OT-wise, similar things that make sense clinically. So Alison does a lot of work on ADLs and equipment, very much discharge planning in those school-based years, which is often after they've had surgery, and helping to get them home. And also a little bit of fracture management throughout, because that's kind of that model where we work together a little bit as we go. But what you didn't see very much there is these current gaps in our service, and the current gaps I think which are being more and more recognised in the literature. I had some students do some literature reviews and kind of come up with what they thought would be useful for research for people with OI, and lots of them spoke about trying to address psychosocial needs of people with OI, because that's where the literature is heading, and people are starting to kind of figure out this therapy, this physio, this OT, but hold on, we're really only looking after the physical at this point in time. So we know these are problems. We know that for parents of kids with OI, if the kids have more pain or if they have lower physical function, the parents have more stress. I don't think I need to tell you guys that. But we also know that kids with OI have some huge strengths. They're really adaptable, they're very clever, they have great intellectual achievements and really, really good coping skills. What they struggle with is isolation, some fear of movement, fear of fracture, fear of injury, lots of fear, and feeling a little bit different. And that's whether you're mild, you're moderate or you're severe, that kids are reporting these things. They haven't done the same work in adults. So we don't know yet. You guys know, you can tell us. But certainly they're the challenges for kids at the moment, and that's what we're not addressing. And it's great to see that over in Perth they actually have brought social work in early in their clinic to try and address some of these things. And again, it comes back to engaging with patients and trying to figure stuff out. So Claire Hill, who's a physio over in the UK, developed the OI Quality of Life questionnaire a couple of years ago as part of her PhD, and she's working on trying to get the adult version of that happening now as well. So kids are just asked to rate between always to never. And these are some examples of some of the questions which are in there. But that questionnaire looks at fear, it looks at function, it looks at pain, a number of different areas. And this is a questionnaire which can be really useful as a clinician to go through with a family, not just hand it over and get it back and move on, but to actually look at the things that families are telling you and trying to put that together with what their needs are, where they think they need help as well. Is it pain? I really think you guys don't tell us when you're in pain enough. I don't think as health professionals we realise, so you've got to tell us, because whenever you do this, pain always comes out as being a huge issue. Fear comes out as being an issue as well. And there are things we can do to try and help manage those, but we need to know that they're problems for us to be able to work with you on them. So having these conversations with health professionals is really important. So in summary, everyone's different and we need more services to cater to more people in their own way. But the big thing is teamwork and clear communication, and not just teamwork within the multidis team, like you guys as patients are part of that multidis team. So we need your communication, we need your teamwork as well, and we all need to work together to make it work. I think as a country we're doing an amazing job, but I think we can also do an even more amazing job in multiple places around the country, and even where we've got very well established services, we still have gaps. And we need to keep on working to get the evidence there, to get the services there, and to take advantage of things like the NDIS. So it'll be great to hear that session tomorrow, see about ways we can actually use that to your advantage to access what you don't have in your centre, in your state, wherever you're accessing services. That's it from me. Happy for questions.
Do you actually need services for people who never got NDIS? We're falling through the gaps.
Yeah, I know. The NDIS has a lot of gaps, which I'm sure you guys will discuss tomorrow. And for people over the age of 65 who couldn't get onto it when it came, it's a major issue. That's a challenge. I think the strength is that it's there now for those other people who probably didn't get services beforehand too. So it's trying to take advantage of that to do our best. But it's a huge problem, without a doubt.
I'm taken, I suppose, by physiotherapy and the connection with OI, because harking back to my own history was with, I went to a school for kids with disabilities, and the physiotherapists wouldn't touch us. Mm. They were terrified of us, and we were terrified of them, because we watched what they did to other people.
Yeah.
And they were very often women that were very muscular and very...
I'm not muscular.
The point of that, I suppose, what I'm saying though, is that one of the things that the my mother initiated, I suppose, when I was younger. I noticed that the graph that you put up of kids sitting up has been a marker. I didn't actually, I could not sit up unaided until I was 6.
Yeah.
That became a marker for me going to school.
Yeah.
I couldn't sit up. But Mum always used to insist on me having to lie down at night. Not at night, in the afternoon when I come up from school. And I've got pretty severe scoliosis, but I've never had any back pain.
It's good.
Maybe I'm fortunate. Or maybe it's an issue of not putting too much stress on your spine in the early days. Not that I'm not opposed to exercise. I suspect that some of the advantages I've had are due to the fact that I started pushing a manual wheelchair when I was at 11, and I kept doing so. I still push a manual wheelchair due to my shoulders, not practically. So I'm very much support your idea of exercise, but given the issues of my own experience, I suspect that it may be a good idea to ensure that there's not too much load pushed on your spine, or at least that you get lots of opportunities for a
break. Yeah. And I think nowadays it's different because your bones need to be strong enough to take your weight of your head and of everything else on top. And back when you were younger, even though it wasn't that long ago, you didn't have the advantages of a lot of the medications we have now. So I still don't think as physios we should be, pushing people to sit up, or OT should be pushing people to sit up. It should be when a kid has the strength there. And like we do with lots of issues, we want lots of tummy time and build that strength and take yourself there when you're ready. It's just that it's happening sooner now because of the medication that we have. And touching on what you said as well, I would have been scared of physios too, and I'm still scared of physios in some places. I've been overseas a few places and it is scary what they try and do. So it's finding the right person, whether it's a physio, an OT, no matter who it is, who communicates with you and understands and is sensible in what they do. Yeah. So Julie?
That was my question. A lot of us don't live near a multidisciplinary team. How do we find, people around here today have been saying, how do I find a physio that knows about OI? And chances are they're not going to know about OI.
Yeah.
But they have to be able to listen to you and work with you.
Exactly. You're never going to have every physio know about OI. You're never going to have every doctor, every OT, social worker. They just don't. But if you can find the right person who's sensible and who listens to you and who asks you the right questions and is happy to talk to other people and find out more, then you're onto a good thing. And hopefully, I mentioned last night, we can try and build more in terms of allied health guidelines, because I think NDIS, you're all going to be seeing much more out in the community, not in the multidisciplinary centres. And with the new services which are happening, say in Melbourne and Perth, it's such a push to get the tiniest amount of therapy. It's really hard to get it, to maintain it, to grow it. And the population is only growing, but we're not getting the same growth in the tertiary level health system. So we need to have better ways of doing it and educating others and working as teams between the tertiary and the community as well.
I think some of that goes to the research as well, because if you're in the medical field, getting funding for physicians in hospital needs data. And unfortunately, that's the issue we've got. We can't say we have X number of people with OI in Australia. We can't say that in WA we need this. And so when you actually go to get funding, they say, well, why? Why should I do it? Where's the numbers? And that's sort of a bit of an issue in terms of getting that data. And that's why I guess the society probably trying to get that sort of information out is really critical. With that data we have from Westmead, we've now passed on to Nicole so she can look at how Perth's performing versus Westmead with what they have, and hopefully we can get more equity as well. That would be nice too. Yeah.
Well, I told the story, we took and found everybody, and then 90% of people won't have medication possibly in their life. They'll need paediatric rehab, multidisciplinary team. Big issues you've identified them, the hypermobility, the sort of delay in walking. Raoul identified all the delayed in motor skills, but you could take out the OI type 3 group and still look at the others and find all these things, and that's why we put energy into them, because of the outcomes. Now the outcomes are, of course, post-school, they're a lifetime.
Yeah.
So we looked at mums and dads and grandmas and grandpas, and in our Victorian study, a lot of that data was never published because we didn't have that. But we did do a lot of data. There's
And I really think we do mild OI. I don't know what you think, Prof, but talking to the therapists, like over in the UK and in Canada, when I was in their hospitals, there were no mild OI people coming in, or maybe one per clinic, versus our clinics where we'll have lots. Because I don't know if it's just their services are so stretched they can't get there, or if they haven't been identified because they haven't had similar things happen all that time ago to find families and to do the education which is being done around Australia to try and get people to pick up on the milder forms of OI. I don't know, but I think we do a lot more of it. I think we're actually really good at it.
I mean, when your service is driven by a Wendy Hawker who comes from, yes, we've got to change the whole landscape of caring for children from a physical point of view, then, and we develop pediatric rehab alongside, then you can see your teams all had, Jenny, yourself, well, you know who they were, and it became evident that, lots of the people with mild OI, if you want to call it that, were having a lot of significant problems that were dealt with, again, from a multidisciplinary team, and even you saw how much orthotics there is. I was very heartened to see that Northcote has now set up a whole service, a 3D printing service for orthotics. That transforms the world, where you don't have to pay $400, you can go and have them 3D printed.
Hopefully they can get through lots more way faster, so there isn't the long wait anymore too.
Yeah, that's right.
Verity, this is an adult question, so it may be
I'll do my best.
your next research, but the observations you're making even in this presentation about fatigue and exercise, I just wonder if you have any further observations on that, because from a midlife type 1 point of view, fatigue is probably the hardest thing I'm dealing with this, apart from it's a soft tissue and hypermobility related problem. But the role of physios in particular in helping us to balance the levels of exercise that promote, that are anti-fatiguing as opposed to aggravating, because there's a very fine line between what is strengthening and what is aggravating. But also the role of physios in helping all of us who are in, have serious jobs to help our workplaces understand what a working day feels like for a person with OI.
Yeah.
So, for example, I've finally got, years and years and years into work, I finally got the kinds of infrastructural supports happening in my workplace, including a bench being installed at the moment, so I can lie down at 3 o'clock when I turn into the Energizer Bunny, or whichever the bunny was that went out steam in the ad, that's me. And I'm trying to convince people that I might start the day full of beans, but it just goes exponentially down as the day proceeds.
Yeah.
So you want me to be at a dinner at 6 o'clock, I've got to lie down or I have to do something else. So to me, it's the physios and the OTs who have a profoundly important role to play for adults in helping us to manage the expectations of those around us as to our capacities, as it's a moving target for us as well.
Yeah.
Like, I didn't expect to get this tired at this point in my life, but I really am, and I can't see how it's going to improve.
Yeah.
So that's part of a really important part of the research that you're doing with children as well,
Yes.
but on the adult front.
So again, there's lots of things. I think it's certainly everyone's telling us about it. Without a doubt, and even, I went and visited an 18-year-old boy the other day, and he'd been out in the morning, come home and had a nap for a few hours before we arrived, and we were there at like 1 or 2, and then he was out again, and that was just how he managed his day. And he was really excited that school was over because he was able to do that, because he's not then falling apart when he gets home from school. So I think we know it's there. I think in other areas of therapy we know ways to manage it. So you spoke about hypermobility, we're getting better at that. We're getting better at managing fatigue within chronic pain as well, but we don't know what causes it. We don't know if you are fatigued because you're a bit weak, or because you don't have the same control, or if because you're not sleeping well at night, or because you have pain. Like, we don't know that part, so we can't really hit it on the head, but we have management strategies in play that we can use. And a lot of it is, again, talking with you guys, and you figure it out most of the time. You come up with the solutions and usually we're just tweaking them. So you get your pacing strategies that do and don't work. You know that some activities push you too far and then kill you. So you then need to completely just sit down and do nothing for 2 or 3 days. So it's trying to help you manage that. I don't think we have a quick fix. I think bisphosphonates certainly play that role in managing fatigue in children, you know, the red cordial effect. But parents, it seems like it. But I don't think it does the same in adults. I don't know, adults don't report that same effect from it. So I think you almost have to become more reliant on managing it yourself and those conservative therapies as you get older. Hopefully Marie and I can tell you more in a year or two. Hopefully, yeah. And hopefully we think more about fatigue too. I think as a broader therapy community, we're not just thinking about pain, we're thinking about fatigue more now when we're doing things.
Just a quick question. After surgery, which I had earlier in the year, not to do with OI, I found sleep was actually, I think, healed me because my muscles were just so weak, and the fact that I knew I needed to sleep, and I would do my physio, but the sleep was allowing my muscles that I just physioed to start to contract. In other words, start to get tighter and work better. And then I knew I'd be okay to do the next sort of physio the next day.
It's a balance, particularly after surgery or fracture or trauma, whether that's physical or psychological. You need to balance your healing time with your doing time. If you don't get enough sleep, you're not going to do any decent therapy of any sorts. So it's getting that balance between the two. And it will change over time. You'll need more rest initially and then less rest.
Yeah. They listened to me. But,
Yeah.
it worked. Eventually the muscles got stronger.
Yeah, it's good.
Andrew, and then we'll
G'day.
Hi.
Firstly, I'm really quite excited by the research stuff you're doing. I think
Oh, thank you.
it's really...
We are too.
I get excited by research. Anyway, the point is, I think it's great that you're looking into it, and I hope, like you said, in a couple of years, it's going to provide some guidance that's lacking at the moment. My question was a really quick one. Where do you sign up for it? 'Cause I don't know...
Great question.
Because you weren't here last night.
Yeah.
Pardon?
Because you weren't here last night.
Oh, what was you last
Oh,
night?
you were here.
Yeah.
Okay, so Marie is over in the corner, blonde hair from Belgium. Stand up, Marie. If you haven't met Marie, meet Marie. Next to her, yeah. So find Marie, find me. We have been inundated and we're so thankful. We're going to try and see people who are outside Sydney over this weekend as best we can.
I'm in Sydney, so
Yeah, we'll book you in for this week. We're ready.
You're not going to be off the radar anymore.
Yeah, and as things come out, Fern's been so supportive. So particularly these questionnaires about trying to come up with allied health guidelines. It's not just Fern, it's the whole OI society. So we'll get those links out to you. We were hoping, we've got Alex here today as well, who's one of my physio students. We were hoping to start one of the questionnaires today, and I can't figure out the IT. I have someone who's teaching me how to use it properly. It's a new system, which is really good for research, but I'm just not quite there yet. So we'll get those links out so you guys can give your voices.
So we'll
Yeah.
put them up on the website. I'm pretty sure we've already got the guidelines and everything up
Yeah,
on the website.
they
So
are.
they're all there. You just need to go and have a bit of a look around. There's a lot of stuff on our website now. It just needs, again, if you find things that you know about, send them through. Get them over to us so we can put them up.
And if you decide down the track you want to do research, or hold on, what was it she was talking about? Like us, Fern, us, Jenny, us, Prof, you can always find me. You can find plenty of us. We're out there.
We know where
Yeah,
to live.
exactly.
All right,
Thank
on that
you.
note, we'll-
Oh.